Hello, my name is Dr. Martin Grond. I'm chairman of the Department of Neurology in Siegen, Germany. I am particularly interested in atrial fibrillation, or AF, because this form of arrhythmia is one of the major causes of stroke worldwide. In current practice, death and disability due to stroke can largely be mitigated by anticoagulation therapy. However, circumstances may arise in which anticoagulant therapies need to be reversed. While the antagonization of vitamin K antagonists can be tried by application of vitamin K and PCC, both approaches may imply specific handling issues and problems. The NOACs in particular have been criticized in the past for a lack of a specific reversal agent for emergency situations. Today, I would like to discuss the reversibility of NOAC therapies from the perspective of a neurologist specializing in stroke. Currently, there is a specific reversal agent available for only one of these NOACs, dabigatran. Idarucizumab is a specific reversal agent for dabigatran. It is a fully humanized monoclonal antibody fragment that binds to dabigatran specifically and with high affinity, able to immediately reverse its anticoagulant effects within minutes. In current practice, however, in dabigatran patients, the immediate reversal of effects on anticoagulation is possible, and real-world experience with idarucizumab in the context of ischemic stroke and ICH continues to accumulate. One example of this experience is a retrospective study conducted in 22 stroke centers across Germany looking at the use of idarucizumab to reverse anticoagulation in dabigatran-treated patients with ICH or ischemic stroke. Thrombolysis in ischemic stroke is considered an urgent and often life-saving procedure. Also, intracranial bleeding is a neurological emergency and usually life-threatening. As we will see for dabigatran-treated patients, idarucizumab might be appropriate in either of these scenarios. Here are some cases from clinical experience. A 78-year-old man was admitted to the hospital after his wife noticed aphasia, difficulty walking, and right facial hemiparesis. An MRI revealed recent onset of ischemia and the presence of microbleeds. The patient was treated with dabigatran 110 for atrial fibrillation with the last dose in the morning of admission. Thrombolysis with RTPI was indicated, but lab tests showed a DTT of 134 seconds. Administration with an IV bolus of 5 gram idarucizumab was followed by thrombolysis 20 minutes later without complications. The patient recovered fully from his stroke and was able to return to a normal, active way of life. An 86-year-old woman with a history of diabetes and arterial hypertension presents with an acute onset of left-sided hemiparesis. Cerebral imaging with MRI and CT revealed a 7 cm hematoma with initial NIHSS of 4. Lab tests revealed a DTT in excess of 200 seconds and an APTT of 44 seconds. Acute reversal of dabigatran anticoagulation was performed with 5 grams of idarucizumab approximately 2 hours after admission. The size of the hematoma remained unchanged the following day. The patient was transferred to rehabilitation after 21 days with NIHSS of 2 and Rankin score of 3 in a stable condition. A 76-year-old man was admitted to the hospital after his wife noticed aphasia, difficulty walking, and right-sided hemiparesis at 2:45 a.m. The patient was last seen normal at midnight. On MRI, there was no ischemic lesion yet. The patient was treated with dabigatran 110 mg BID for AF with the last dose 8 hours before. Thrombolysis with RTPA was indicated, but lab tests showed a DTT of 121 seconds. Administration with an IV bolus of 5 mg idarucizumab was followed 10 minutes later by thrombolysis without complications. The patient recovered fully from his stroke and was able to return to a normal, active way of life. An 83-year-old man with a history of arterial hypertension presented with an acute onset of severe left-sided hemiparesis. Cerebral imaging with CT revealed a 7 milliliter thalamic hematoma with ventricular extension. Initial NIHSS was 9 points. He took dabigatran for atrial fibrillation 110 mg with the last dose 7 hours prior to admission. Lab tests revealed a DTT of 119 seconds. Acute reversal of dabigatran anticoagulation was performed with 5 grams of idarucizumab approximately 1 hour after admission. The size of the intracerebral hematoma remained unchanged the following day. The patient was transferred to rehabilitation after 9 days with NIHSS of 3 and Rankin scale of 3 in a stable condition. Reversing the effect of dabigatran with idarucizumab is feasible, easy to manage in an emergency room setting, and may enable dabigatran patients presenting with an ischemic stroke to be thrombolized with RTPA or possibly prevent hematoma volume growth in dabigatran patients presenting with ICH. Although more data is needed on these topics, real-world data continues to accumulate.